My name is Amy Taylor, and I'm the Community Liaison to the Amarillo Branch NAACP. Thank you very much for taking time out of your evening to come learn about and ask questions on opioid abuse in the Panhandle from our panel of experts. To me, it seems as if there's a paucity of coverage on this subject. Personally, I've heard many stories. I have two friends who have lost children to this scourge. One friend whose child is in Huntsville, and another whose son is unable to visit their home because they're raising his child. And yet, when I hear the topic covered in the press, I get the impression that the problem is so much greater in Ohio or West Virginia or Vermont. So tonight, we're here to learn about the depth and breadth of the problem here in the Panhandle. With that, I turn it over to Karen.
Thank you, Amy. Hello, I'm Karen Welch, and I'm a producer at Panhandle PBS. And Panhandle PBS is privileged to partner with the Amarillo branch of the NAACP to help host these community conversations. We also thank the Amarillo Public Library for joining with us in these forums and providing some resources. They've got a table of books that are at the back, and those are available to borrow. As partners, we believe in reaching as many people as possible with information and discussions that are vital to our community. Tonight's event is being streamed live on the Panhandle PBS Facebook page. So if you see that, please share it. We will also upload the video to our panhandlepbs.org website. We'll start with a series of questions and leave some time for you and the audience to ask your own. Opioids, as Amy said, have permeated our society. On average, opioid overdoses took the lives of 115 Americans a day in 2016. In 2012 alone, physicians wrote 259 million prescriptions for opioids, enough for every American adult to have his own bottle of pills, according to the Centers for Disease Control and Prevention. The CDC also estimates that more than 1,000 people are treated in emergency departments every day for not using opioids prescribed as they're supposed to be. Now let's get more local. You might be surprised to know that one study placed Amarillo among the 25 cities in the nation with the highest opioid abuse rates. We're at number 13 on that list. The same study by Castlight Health, an employer benefits company, also ranked Amarillo 10th on the list of 25 cities with the most opioid prescription abuse. So this conversation couldn't be more critical. I'm pleased to introduce our panelists for this evening. State Senator For Price of Amarillo joins us. He is the appointed chairman of the Texas House Select Committee on Opioids and Substance Abuse, which recently launched its own hearings on multiple aspects of this issue. And I'll note here that in Texas, opioid-involved overdose deaths rose 400% from 1995 to 2015. Martha Burkett is Director of Residential Services for Amarillo Recovery from Alcohol and Drugs, known as ARAD. She has extensive background in addictions counseling and psychology. And because the crisis involves not only prescription painkillers, but a growing underground market for illegal synthetic opioids, we are glad to have input from Amarillo Police Chief Ed Drain. Welcome to all of you. Thank you. Martha, would you start us off, please, with explanation of opioids, what they are, and what are we dealing with?
Well, opioids are usually used for pain relief, and they are the names of the drugs that are commonly heard are OxyContin, codeine, morphine, fentanyl, Vicodin. There are other synthetic opiates that are used for pain as well, and of course there's heroin, and which isn't going to be prescribed for medicinal purposes. Obviously, that's going to be on the street. But these are drugs that are highly addictive. A lot of the time, people get addicted to them sort of by what I call legitimate means, which means that maybe they have legitimate pain. And they go to their doctor and they get a prescription for codeine or Vicodin or something like that, and they're taking it. The thing about opiates is that they hit on the pleasure centers in the brain, and the way that they affect the dopamine system inside of the brain makes them really highly addictive. So the psychological addiction can happen as quickly as 2 days. The physical addiction can develop in as quickly as 6 to 8 weeks. So hypothetically, somebody who has hip surgery and gets put on codeine could become physically addicted to the drugs. And some people, you know, they don't have that problem, but lots of people do. And what happens sometimes is that people get legitimately, you know, they start out with a legitimate need for the drug, they become physically addicted to it and psychologically addicted to it, and then maybe they're trying to get their prescriptions filled too quickly, or they're trying to kind of go past the time when a doctor would expect them to be still needing the pain medication, so the doctor says, no, I'm not going to, so they take them off, they stop writing the scripts. Well, the problem is that that person has a physiological addiction at that point in time, and the physician isn't necessarily referring them for treatment that's going to help them with the withdrawal. So in essence, that person who's become legitimately addicted is in withdrawal. And in that state of withdrawal from opiates is not deadly per se, but it's really, really uncomfortable. It's just miserable. There's fatigue, anxiety, diarrhea, constipation, you know, sleep disturbances, appetite disturbances, mood disturbances, you name it, but also there's a physical response to it where it feels like, I've heard people describe it as it feels like somebody's pulling my muscles off my bone. So it's physically painful. So here's this unsuspecting person who is experiencing these symptoms, and their brain is saying, more, give me some more, give me some more, give me some more. So they seek it, and they end up going out on the street and getting either buying the pills illicitly, and then that becomes a whole other range of activity, or they discover, and then if they run out of money or they run out of access, then that's when they'll switch to heroin, because that's a lot cheaper and it's easier access, so it's less expensive. Kids, you know, this is a drug. These drugs are, a lot of young people are being really seriously affected by this phenomena, this epidemic. I mean, there's not another way to talk about it besides epidemic, but years ago, as far back as 15 years ago when I was in Michigan, there were treatment centers that were just absolutely inundated with kids ages 18 to 24, 25, 26, whatever, who were addicted to opiates, and a lot of them to heroin. And it was upper middle class kids who had access to money and had mobility and had freedom and not so much supervision, and so it became this thing where these kids, and they were getting, some of them would start out getting their medications, some of them it would be maybe a sports injury, so they would get prescribed an opiate to help them deal with their pain, and the coaches are keeping them on that while the time that they're competing, because it makes it possible for them to continue to play the game, whatever their sport is. And, you know, then all of a sudden they don't have access to it anymore. So maybe they're going into mom and dad's medicine cabinets and that kind of thing. So having access to it in that way, but then of course these kids have a lot of disposable income. They believe they're invincible. They're risk takers, you know, and this is exciting. It's kind of glamorous, whatever. That was kind of it was sort of a social phenomenon. And then they started dropping like flies, and all of a sudden their parents were just up in arms, and so there was a lot of attention that got paid to it. But the same kind of trajectory was happening there, and the same thing with the pain medication and so on and so forth. And then I was in Virginia, and it hit there really, really hard. And for them, it's mostly the pain pills, but again, it's the same kind of thing where they become addicted to it, they can't get access to it anymore, and then they go to the street drugs. So, you know, why is it so addictive? Like I said, it hits those pleasure centers in the brain that make you feel, opiates make you feel good. So, you know, I mean, there's an immediate reward involved in it. And so if you have psychological issues, if you have social issues, if you have psychic pain of any kind, then it's an easy way to numb that too. So long past the time that a person needs the physical analgesic, they start to do it as a way of self-medicating, and so then it becomes self-fulfilling, you know, and that's the way it is with addiction to any substance. But so, you know, it's really alarming because the abuse, I mean, even in Amarillo, I was looking at statistics today, and in Amarillo, the statistics show that 8.2% of those people who are prescribed opiates are misusing the opiates, okay? And what that translates to is that 47% of all the prescriptions filled, opiate prescriptions filled, are being abused.
Wow.
In Amarillo.
So,
Okay.
Representative Price, what you've had your first hearing on this issue. It's so multifaceted. What struck you out of what you were hearing from numerous agencies and medical associations and things like that?
Well, first, I want to thank PBS and NAACP for actually bringing attention, locally to an issue that is not only national, but certainly hits us right here at home, because this is really key to actually addressing some of the problems. What we've learned is that, awareness and education is a big component of how we can make some progress and improve outcomes and really prevent some of the abuses that we're hearing so much about. And the statistics you rattled off are pretty alarming. When you think about federally, over 2 million people are estimated to have an opioid-related disorder. And so you talked about the 42,000 overdoses coast to coast. And in Texas in 2016, that was 1,376. And so there are a lot of individuals that are not only affected, but the scope of the problem is quite large. And so what we heard at our first hearing was not only the scope of the problem, but what it costs and indirect costs to individuals. So when you look at lost productivity, time away from work, societal costs, criminal justice costs, some of the things, ER costs, unnecessary admissions into the hospital, things of that nature, it is in the hundreds of millions of dollars for Texans. And we are by no means, immune locally from those same problems. So what we heard was a lot of interesting testimony, and perspective historically I think is important here. We heard a little background about how back in the 80s, the mid-80s, there was a lot of pressure on physicians to treat pain, that they might not have been treating pain quite the way it should have been treated, and there was a lot of criticism in the medical community about that. And about that same time, there was more and more prescriptions for opioids being provided. And then not too many years after that, the early to mid-90s, was the recognition of what was called the fifth vital sign. So when doctors and nurses and medical professionals start to take your blood pressure and your temperature and check some of your vital signs routinely, they would also ask you if you had pain on a scale of 1 to 10, where are you? And so that became part of a protocol, and people became more aware of that. And the prescribing of opioids when someone was suffering from pain just increased in its prevalence. And so there was probably some period of time where, maybe the prescribing protocols and the days of prescriptions, the use of them, for instance, instead of maybe prescribing something for 3 days or 5 days, it was being prescribed for 2 weeks or 30 days at a time. And there are some issues there, and that maybe not everybody was aware of. So I think we've seen this epidemic grow. The president's declared it a national public health emergency, and certainly in Texas, with the forming of the committee that I'm privileged to chair, we are really trying to drill down on not only how big the problem is, what populations it's actually affecting, and where. You mentioned Amarillo was one of the top cities, top 25 cities in the country. There are actually 4 cities in Texas that were identified. It was Amarillo, Longview, Odessa, and Texarkana. And, 3 of those 4 cities are near other bordering states. And so practices like doctor shopping and that sort of thing is probably easier in areas where we are. For instance, you can pick up a prescription here, and it doesn't take you long to travel to New Mexico or to Kansas or to Oklahoma to try to seek, a similar prescription if you were intent on doing that. So there are some problems with that and states communicating. But the legislature is looking and has done some things over the years, and I'll go into more detail later, but honestly, some of the things that we're looking at and working on and have been focusing on is, one, making naloxone more available over the counter to pharmacists with a standing order so that folks can get that drug to have on hand in cases of an overdose, which is to treat an overdose in an emergency. Which is very important. And also we have a prescription monitoring program that was passed previously, and it was strengthened. So it was passed in 15, it's strengthened in 17. It's going to take a while to phase in, so it's it's yet to see, you know, how effective it will be. But essentially, it's not to put handcuffs on physicians, but it is to also crack down on what I call bad patients. And so when somebody is going around to shop for multiple prescriptions, this monitoring program is going to be in place so that physicians can check it to see, you know, maybe how frequently a patient has received a opioid prescription in the past. But then also when the pharmacy fills it, they can check the same program. And so it's meant as a preventative measure to sort of eliminate some of the bad practices that have occurred in the past. And so those are some of the things that we looked at and we will continue to look at. And like I said, I think, you know, the CDC guidelines on prescription days or the amount that is recommended for prescriptions of opioids is something we can look at very seriously in Texas. I think the testimony we heard is that these are so addictive that after the third day and after the fifth day, those are really critical time periods. And so to limit the number of days a prescription might be available for use, or the number of milligrams or pills, for instance, really is a good idea for us to look at, because yes, there may be more administrative burden, but gosh, you know, to really crack down on those, you know, folks who are taking pain medication legitimately to ease that pain but manage it correctly and not end up in a situation where somebody becomes addicted, really prevents a lot of the problems that Martha was talking about down the road, whether it's obtaining illicit drugs, using drugs that were unused, or, you know, maybe stealing some out of someone else's medicine cabinet, for instance, and even selling them. So some of these problems that I'm sure Chief Drain has faced and deals with, you know, we're hopeful that we can impact not only legislation that will make those situations better, but also just make some recommendations for best practices, which may not require legislation, but may be, you know, for instance, treatments and protocols and things that we can do as communities across the state to make our situations and outcomes a little better.
You've mentioned that kind of the doctor shopping and the ways that, even if it's not a good way to get it, ways to get it legally, but how easy is it to get these drugs either legally or illegally? Chief Drain, what do you see out there as far as what people are using and how easy it is to get something in your hands? Well,
and I don't want to, I totally agree with Martha and with Representative Price that the opioid problem across the nation is huge. 63,000 people, I think, died in 2017. But I'm going to be frank, here in Amarillo, though, because we have a bad drug problem here, and I want us to stay focused on that. But to be frank, though, I'm not seeing opioids as our biggest drug problem here. Our drug problem is meth. And I say that because if opioids were our biggest problems, we would see that more when we arrest people, not necessarily doing drug investigations, just petty criminals out there breaking into cars, breaking into homes. We catch them, they got a little dope on them. And I get a report every morning of who we arrested, and it's meth. It's meth, you know, and there's always marijuana. Everybody's got a little marijuana on them. Occasionally some cocaine. And then the other problem we're seeing are the synthetics are getting much more powerful now. And when I got here, when I asked about the overdose issue, we actually weren't tracking our overdoses. So I have my special crimes unit doing that now. So we just started in 2016. But in 2016, the deaths, and we have to keep in mind here in Potter and Randall County, unlike some other parts of the state, like down by the Metroplex where I came from, any unattended death went to an ME, a medical examiner, and an autopsy was done. Here, a JP has to come out and has to order that, and they don't order, in all cases, they don't do that. So we may not have the data that we need, but in other words, we could have had some overdoses where no autopsy was done, so we don't know. But it was...
Is that because the counties contract with a medical examiner in
We do.
Lubbock?
We contract, both counties contract with the same pathologist's office down in Lubbock who does our pathology work, our medical exams for us. But as I said, we don't get those in all cases. In 2016, according to the data that we have, we had 34 deaths total from overdoses. We had 22 in 2017. Opioids, and the one that's the biggest category here, which is going to be common, is acute combined drugs. So they died, they've got multiple drugs in them, and that isn't broken out. So some of them could have opioids, they could have cocaine, they could have marijuana, all of that in their system. But for the data for 2016, just a, we've got 1 hydrocodone, tramadol is an opioid, we've got 3, and then we've got an acute heroin intox, 4, so looks like about 6 or so of those are related to opioids, which, you know, that's a tragedy for those families. But, and I also looked at our overdose rate. You know, you can go to CDC and then they can pull up data by states. And our overdose rate for Powder County is about 16 per 100,000. I think it was 11 for Randall County. That's higher than it is for the state of Texas, but it is much lower than some of those other states out there, like West Virginia and New Hampshire, and some of those places. I saw the report that you saw, and it didn't talk about deaths. It talked about abuse, and I'm still not clear how they're tracking that data. Representative Price mentioned that there is some drug surveillance system in place. The DEA, we're part of the DEA office out of Dallas. We have a small DEA office here. So I asked those guys to go back, and there's a section within DEA where they track surveillance on just the prescriptions, and they're a little busy right now because so many jurisdictions are suing the medical companies. A lot of people are asking for that data, so I actually haven't gotten that back yet. But they said that there's no way that that report, in their mind, is accurate for opioids for our area. That was their view, that we would be that high in the nation, because if we did, we would see more overdoses, and I think we would see more drugs when we do our arrests. We are seeing a lot of drugs when we do arrests, but the drugs we're seeing is meth. And meth is a very bad drug. There is no question about that. But you tend not to have the overdoses, the acute overdoses, as quickly. You know, it kills you over time, unlike the opioids do. Now, we have been seeing a trend with the MDMA, the efficacy. We had some kids that did overdose. They did not die. There were trace amounts of fentanyl that was in those drugs. That's the drugs that a lot of kids take. And so if they're buying that stuff off the street, you know, they're taking a chance. We intercepted a load of about 200,000 pills that was not trace amounts. Someone actually had put it in there to get a bigger high, and that's also a trend that's going on around the country. So we may be on the front end and where we haven't caught up with the rest of the nation when it comes to seeing the opioid problem.
And I think Martha was talking to me about that earlier. So you think we're just at the start, behind that curve, which we don't really want to catch up, but
yeah, we don't really want to catch up, definitely. It's not a distinction that you seek, but just anecdotally, when I got here and I first was going to the ROSC meetings, which is the Recovery-Oriented Systems of Care, and this conversation came up, and it was a bunch of treatment providers sitting around, and everybody kind of looked at each other and went, well, but we don't have an opioid problem, you know, and that was kind of the consensus in the group of treatment providers, and I was sitting there thinking to myself, well, and there's an assumption, and everybody said the same thing that you said, which is meth is the primary problem, which just in my short time here, I'm able to support that assertion, you know, just anecdotally. But I think because there's that assumption, there's a little bit of a bias too, that it's like, oh, this is what's happening. And so I asked, the question is like, well, what are we asking them on the assessments? What kind of questions are we asking when we're screening people? If we're just assuming that they're not doing this, are we asking, or how are we asking the question? Because if you say, well, you're not doing any opiates, are you? And go to the next question, then you're not going to get an accurate report from that person. And the thing is that if somebody's misusing substances, they're going to be a little bit guarded, they're going to be under-reporting, they're going to be minimizing. So you just gave them a free pass to not talk about a whole bunch of stuff that could be really critical to their health and to their potential to be able to recover successfully. So I don't know that that's happening, but when I tossed out the question, people kind of went, oh, you know, and also there was an assumption around the table that when we were talking about opiates, we were talking about heroin. And people were saying, well, but who's using heroin in Amarillo? And then there was, and I said, well, you know, opiates are not just heroin. I mean, it's pain meds and prescriptions and that kind of thing. And it's, so I think, I mean, there's a paradigm, you know, kind of a mental paradigm about this even among treatment providers. And I think it's because of the fact that it has been true that methamphetamine has been the primary problem. What I've heard ever since I got here is meth followed by alcohol. And so today I was digging just on, you know, within our own agency, asking, you know, okay, how about in the shelter program? How about in our program? You know, what's showing up, and also at Downtown Women's Center. And what I discovered is that for us, it's 5% of the people that we've admitted. Okay, our program has been open for 10 weeks, 11 weeks. So our number is not very high. But out of that number, it's 5%. The same goes for our shelter program, 5% of the people. And this is since January. We've only been tracking since January. So in that time, but what Skylar said to me, Skylar Mueller, who works at the shelter program, is she said, I wasn't tracking this stuff last year, but just anecdotally, just based on what I know, because she interfaces with the participants every day, she said the numbers are going up. Already there's more people telling me about it and talking about it. So this 5% is actually an increase as opposed to last year. When we talked to Diane Gilmore at the Downtown Women's Center, she said that right now, opiates are second. Meth is first, opiates are second. It used to be that meth was first and alcohol was second. So there's a little bit of a change. And even though the numbers aren't real high, there's an indication that it's changing, that it's trending in a certain way.
The trend for our state is not good.
Right.
And the issue with meth, Amarillo is a part of something called the HIDTA, High Intensity Drug Trafficking Area. And we're part of and there are 2 HIDTAs here, one in Dallas and one in Houston. There may be one out west too in El Paso, but and the one in Dallas is called the Texoma HIDTA. So it has North Texas, including our area, and then parts of Oklahoma. And what the HIDTA does is you have it's basically local police officers working with our federal partners, and we meet and we try to come up with strategies. But they put out a report every year on what are the big drugs that they're seeing. And for some reason, in North Texas, in Oklahoma, in our part of West Texas, the problem is meth. I mean, that is the drug that's the drug. I don't mean that we're just getting our pocket trash. That's where the drug dealers are focused. I mean, we're talking high level now when we're talking about the HIDTA. The problem is meth. And now the trend may be moving towards opioids. And I think part of that is, too, is, as most of you know, there used to be meth labs everywhere. When was the last time you heard of a meth lab? Because you can't make it cheap enough, and because also it's harder to get the precursors to make meth now. But in Mexico, they can make it so much cheaper and bring it across in a liquid form. The price has just dropped dramatically, and it's much, much cheaper to get meth here than it is to get opioids. And we're so close to Mexico. Again, this is anecdotal. I can't, I don't know what's going through drug dealers' minds, but that is the drug that people are using. That's the drug that people are dealing here, primarily in our area. In fact, in most of Texas, because Texas overall, again, the trend isn't good, but our overdose rate is much lower, again, than some of those East Coast cities and those Midwest cities, much lower. I mean, they're at some of them are at 30 per 100,000 deaths a year just from opioids alone. And again, our state is around 10 or 11. We're higher than that here because we do have a lot of drug use here. I'm not trying to minimize that at all.
Right.
We have a very, very serious drug problem, and it's contributing to a lot of our property crimes here in particular. But I don't think that people are still as much here to buy opioids as they are to buy meth and some of these synthetics.
Thank you. Representative Price, there was testimony about the black market at your committee hearing as well, and the fentanyl is a big, serious question right now, isn't it?
Well, it is. It's so potent. It's so strong, and it is used or laced in other drugs that present such a danger. So we talked about that, and one thing that occurred to me is I was listening to Chief Drain and when Martha, talked just a minute ago. One thing I didn't know at our last hearing, one of the I guess, dangerous trends with opioids is not just overdose-related conditions when you take an opioid by itself. It's when you combine that opioid with a benzodiazepine like a Xanax or a pill like that and a muscle relaxer. In our committee hearing, they refer to that as the Houston cocktail, and I don't know why it has that name, but apparently that is a very, very seriously deadly combination of drugs because it slows down your respiratory system and you basically suffocate. And so fentanyl has very potent qualities that will cause that condition. So we talked about medication cleanouts. We have one here in Amarillo that Texas Tech Health Science Center operates periodically on its campus, which I attended they just recently had one. I think I went to the one right before this last one. And it was amazing to me how many pounds of unused medication they are collecting, which is a really good thing that they are doing this. And so to get drugs, you know, legally prescribed, I'm not talking about illicit drugs, I'm just talking about legally prescribed drugs out of folks' medicine cabinets, unused drugs out of parents. You know, all of us have family members or aging parents who sometimes, it's amazing, you go into their medicine cabinets and you will see just, you know, shelf after shelf of unused medication, or now mail order medication. A lot of it just shows up month after month. And so there are real problems with proper disposal of medication. People are just generally, I think, unaware of the proper way to dispose of it. So we heard testimony about carbon pouches and how you can store medication in there to reduce the potency, or some of the methodologies to do that in medication cleanouts. I think some Walgreens across the state actually have some drop boxes, that's what I call them, but they're boxes where you can take your unused medication. And just getting it out of your possession correctly is an important step. It sounds like a really logical, easy, sort of common sense thing to do, but we saw that just folks all over the state weren't necessarily in years past taking advantage of that. And so what that did was provide either somebody to self-medicate because it's there, or they sell it, or their kids or a family member takes it and uses it themselves or sells it. And so it's become something that you know, conversations like this, I think will help raise awareness that there are options out there to really take care of it properly, and it'll help that illicit drug trade.
Funding for programs and things is always an issue, and I know that President Trump declared it was a 90-day public health emergency that was extended for another 90 days recently. That released some funding in the bipartisan budget agreement that Congress passed on February 9th, dedicated $6 billion in funding to fight the opioid crisis. But some people are talking that this is like the tobacco lawsuits, that this is like it's going to take billions rather than just a few billion to do this. What can the state dedicate? How can this work?
Well, there's a couple of things happening right now that I think we should be aware of. One is the Substance Abuse and Mental Health Services Administration, which is a federal agency, has granted Texas through what's called TTOR, which is the Texas Targeted Opioid Response Grant. And everything has an acronym, but that is the grant that is $27.4 million for each of 2 years, which, you know, is a good amount of money for prevention programs, for outreach, for treatment and recovery programs across the state. The problem, as I see it, since I'm from Amarillo, is that these are targeted towards highly populated metropolitan areas across Texas.
I had a question
They're not
about
necessarily, you know, we're not going to really be able to participate in the TTOR program or the grant monies. And so, you know, sometimes when you hear about federal money and you talk about big dollars, it sounds like everybody's sharing to a large degree in that money, and that's not always the case. And so we have to, you know, I think, spend time, you know, at the legislative level, educating our colleagues about the dollars that we are going to appropriate to, for instance, the Department of State Health Services to operate prevention programs, outreach programs. We need to make sure that any money that we're pulling down is allocated in a responsible way, in a fair way. And even if the studies, even if the data is you know, not clear or arguable in terms of, you know, which cities are suffering, I mean, there's no question rural communities, and ours is one of them, you know, has needs. And even though we are out in front maybe of some other communities across the country, you know, being proactive will be a good thing for us. And so if we are able to do that in a comprehensive way, educate our colleagues about where we are in the state and why it's important, and you know, use that money that way, I think that would benefit all of us. So it's always a challenge. Resources are always that way. But when we hear these big numbers, I think it's important to understand that not all of it gets funneled to all communities in equal proportions.
Right. And I had a question about that, so you got me. Chief Drain, you mentioned the lawsuits that counties and cities are filing against the pharmaceutical companies, and that's difficult to get your statistics. But they're seeking to recover some of those costs associated with drug arrest and jail costs and things like that. What is the expense when you're dealing with a drug arrest? And in this case, it can be opioid or meth or whatever. Just talk a little bit about what expenses the police department sees.
Well, I think the expenses that we see, really, I think that's really just a drop in the bucket to the real cost of drugs, which is the deaths that it causes, the devastation that it causes to families, the amount of crime that it causes out there. So much of our property crimes, people's cars getting broken into, their homes being broken into, it's related to drugs. And so that's where the biggest cost is. And my brain isn't big enough to quite figure that out, but I think we all realize that that is a huge drain on us. And it causes just so many other social problems, from domestic violence to child abuse to sexual. It's just all kind of problems out there related to people being on drugs and narcotics. And just thinking of the lost productivity and all these ghosts that are walking the street when I ride out with the officers over in San Jacinto. Those are people that are not working and they can't go back home with their families. I don't know how to measure that cost, but but it's huge, in my opinion.
Martha, we went through a couple of decades without a residential treatment center. Now we have yours. Is that enough?
Is it enough?
Yeah. What do we need as far as treatment goes?
Well, funding. You know, people don't have, I mean, by the time that people need residential treatment, a lot of them just don't have resources to pay for it. And so, you know, ARAD is there, but our shelter program is there for those people who truly can't pay and who are indigent and can go live in a shelter and get the treatment. We're a fee-for-service. You know, we have a set fee for our inpatient program, and we have a sliding fee for our intensive outpatient and our outpatient programs. We're priced very competitively, but still people have difficulty coming up with the funds to pay. So, you know, there's OSAR. People can go through Texas Panhandle Centers and to get to OSAR, which is the gatekeeper for the state funds for treatment, and there's not enough money. You know, there are too many people who need the treatment and there's not enough money. And so when people call us, if they're not a candidate for our program, I mean, we'll do an assessment on anybody for free. And what we do is we bring them in, we do a comprehensive biopsychosocial evaluation, we'll give them a DSM diagnosis, we'll talk to them about what recommendations we have. And if our program isn't the right fit for them, then we'll make a referral to somewhere else. So we'll send them either to our shelter program or we'll send them to OSAR. Or my counselors have been around Amarillo area, Texas Panhandle for a long time, so they know a lot of community resources that they can send people to, but a lot of time there's a waiting list or there's some cost involved, and if somebody's truly indigent, even that cost is prohibitive. And so I think the biggest thing that's missing, you know, there's talk about the money for, and it kind of, right now, I think the trend is, well, we need prevention because we need to stop people from having these problems, and I get that. But we have so many people that have the problems that need treatment right now that prevention isn't going to address their needs, you know. And so having more funds available that are earmarked for that, you know, finding some way, you know, we have funded, ours is a nonprofit, we funded it through grants and donations. You know, the generosity of Amarillo has funded this program, and it's an amazing, amazing thing. But, you know, as people have to go to you have to go to Lubbock, they have to go to Midland, they have to go to San Antonio, to Dallas, to Houston, to get treatment. You know?
Did your committee address availability of treatment yet?
We did address it, or we started. We haven't made a lot of headway on that specific area yet, but I've talked to Martha about this before, and something that I've learned recently that I guess I just wasn't aware of was how difficult it is for, you know, and specifically for someone that is addicted to opioids to receive treatment. And so I said, well, why is that the case? And, you know, I guess, and I'm going to venture into some medical terminology, so you can correct me, Martha, if I'm wrong, but, you know, there's kind of 3 different major drugs that are effective with medication-assisted treatment, along with counseling, which I think is very important for someone who is trying to recover from their addiction. But that would be methadone, which we've known about for a long time, but that is a very prescriptive, highly regulated type of drug that is dispensed under, very tight conditions, and not everybody would function well taking that or has access, so that's difficult. Secondly, there's naltrexone, which don't confuse that with naloxone, because I've done that before. They are very different drugs, but naltrexone is effective, but you have to have some training as a physician. I think it's I heard in our testimony it was 8-hour course, which doesn't sound like a lot, but you got to go through the administrative burden with the DEA to be approved as a physician to dispense that, and a lot of folks just don't do that. And then third, there's Suboxone, but I think that's the brand name. Is it supramorphine? Supranorphine, I think.
She's
anyway,
been nodding at everything.
but also, I guess what I'm getting at is these drugs are effective, but it is somewhat difficult to find a physician who will treat you. Maybe that's not a pain specialist, for instance. And so I had an individual in Amarillo who, once we started these hearings, contacted me and said, look, I'm addicted and I have to go to Lubbock. This is a story I shared with Martha, regularly, once a week, to receive the medication I need to overcome my addiction. And he said, I've been doing this for 2 years. And he said, I have the wherewithal to take time off from work and drive to Lubbock and receive that type of medication. But he said, 9 out of 10 people are not going to be able to do that. And so something that I want us to look at is incentivizing somehow, whether it's through higher reimbursement rates or required education coupled with, some incentives to our medical community, so that we broaden the access or the network of physicians who can treat. Because as Martha just said, I mean, we can spend a lot of money and will, I think, on prevention, but the facts are there are a lot of folks who are in that period where they need treatment and they need to have the right kind of treatment. And if we are not, doing a good job as a state in at least providing some avenues in communities in all 254 counties, that's really going to be a problem. I think there's only 85 counties that have a methadone, have access to methadone treatment right now. Right. And so you're looking at a very limited, group of healthcare professionals that can really treat addictions in this area. So, I think the more we can do in that area would be good.
All right. Can I just add something
Yes.
to that? And that's not to say that the only way to get clean from opiates is medication-assisted therapy, because that's not true. But for some people, that's really effective. And I was really surprised when I got here to realize that there's actually kind of a bias against it in the medical community, that somehow there's this idea that it's like, oh, well, then we're enabling them to just stay addicted. I mean, there's kind of a lack of understanding about the protocol, and even about that it's a totally legitimate form of treatment for certain individuals. And so that kind of surprised me. But it is possible to get clean from opiates without doing those things for some people. So if somebody comes to us for opioid treatment, we're not doing medication-assisted therapy. We're doing other holistic treatments that help them with the withdrawal and help them to regulate mood and their sleep and so on and so forth. We're doing auricular acupuncture. We have them doing yoga. We have them doing meditation and, all these different kinds of things that help their brain to kind of relearn. So there are different ways to do it, but I do agree with what For Price is saying, that there needs to be just more education about it in this community and statewide, I think, so that there is access and people have choices, as opposed to there being one way to do this,
Right.
Because for somebody who's addicted to heroin or even, other opiates, the notion of coming off of that is really scary and mind-boggling. And the thing is, because the withdrawal is so painful and so uncomfortable, they think they're going to die, even though in most cases they're not going to. I mean, the exception to that would be somebody who's been on high levels of morphine for an extended period of time, and they go cold turkey. They can go into withdrawal that's similar to alcohol withdrawal that will cause seizures and heart attacks and that kind of thing. It can actually kill them. But So if you're feeling like you're literally going to die, then it's really hard to just stop doing something or even venture into a treatment facility that can help you stop doing that thing.
I guess what I want from each of you, we're going to wrap up and have time for some questions from the audience, but your strongest takeaway from what we've talked about here, and also what can we do politically, what can we do to act more responsibly maybe with our doctors, and how can we interact with each other better to start dealing with this problem and other drug problems that we have. Chief? you got nominated.
What can we do? That's really a good question. That's probably one where Martha is probably more qualified to talk about that than I do. But whatever we can do to keep our kids from getting exposed to these drugs in the first place. I mean, we have, and again, I know we're talking about opioids, and one of the things that I hope that comes out of this, Representative Price and Martha, that as we look for grants, as we do legislation, that it's not just focused on opioids, because for parts of our state, that's not the big problem, even though we have a big problem. And so that would be the biggest takeaway that I would have out of this, is that we still, even though opioids is trending, we still need to focus on the meth and the synthetics, because some of those things are killing our kids just as well, from the data that I'm seeing here.
Okay. Martha?
Yeah, I mean, I guess it's not a new takeaway for me. It's the takeaway that I have every day when I get up in the morning and go to bed at night, and that is that, substance misuse is a national health problem. And it's not one drug. I mean, alcohol has a huge health problem. Methamphetamine, heroin, whatever. I mean, you can name your poison, but it's epidemic. It has been epidemic in our country, and I think that as a culture, we just need to be looking at how we celebrate, how we commemorate things. You know what I mean? It's just like the role of these things in our culture and in our lives, and so, I think that's one of the ways that you get at the children is by developing a culture within your family and within your community and so on and so forth that doesn't revolve around substance use, and if there are families that are having those issues, then providing them with alternatives and options and making it possible for them to get education and treatment, and making sure that there are robust prevention programs in the schools. But also, I think that educating families is huge. Instead of targeting one individual who has a substance use disorder, engaging the entire family, or family of choice. It doesn't have to be blood family, but that person's tribe, if you will, whatever, the people that they surround themselves with, engaging them in the treatment and recovery process and educating them and getting them to be aware of how they've been interacting in a way that may or may not be helpful. So I think all of that is really important, but I really do think that what we demonstrate, with our actions speaks volumes to children, especially. So I think that's the best prevention that we can do is to be really mindful and to educate ourselves and to, as a community, create activities and events and opportunities that are family friendly, that are not alcohol-centric or other drug-centric.
Thank you. Four?
Yeah, I think, I want to reemphasize something Chief Drain said, which is, while we are, I guess for purposes of this, panel discussion really kind of focused on opioids, substance abuse at all levels, and certainly across, our local community and across the state is something that is significantly causing not only deaths and tragedies and families, but it is immeasurable when it comes to the indirect costs and the things that we're seeing, how folks are affected at the, in the education system and in the healthcare system and in the criminal justice system and just in the workplace. I mean, they're just almost immeasurable losses. So, the scope of these problems is something the more I hear about and the more I learn, the greater impact, I think, and the more urgency I feel that as a state we can develop policies that really will make a difference and can make a difference. Certainly, you know, I really believe politically this is kind of an area that it is not totally unrelated to what I worked on in 2014 and 15, leading up to the session, and in that cycle, you know, in 2017 for the mental health work that we did, because often substance abuse is a co-occurring condition with mental health disorders. And so it doesn't matter where you live, what your zip code is. It doesn't matter, you know, if you're Republican or Democrat or wealthy or poor or any of that. It really doesn't matter. These are problems that are affecting everybody. And you can't, you know, work with peers or have family members. You know, I'm certain that everybody in this room knows somebody or has somebody close to them that has suffered. So statistically, it is worth our while to focus on it, and it is something that I think, you know, as long as there's good education and community involvement, and you get over the stigma, which often, you know, is one of those things that's hard for people to talk about. If we, you know, as a community, really kind of grab it by the you know, the horns and deal with it straight on and up front. You know, we are in a position, at least with the opioids, to, I think, get out in front of some of the problems that other states have suffered more dramatically than we have to this point. But if we don't, then I think we will find ourselves reacting instead of being proactive. And so that is something that, you know, a big takeaway for me is politically, I think you can convince, you know, everyone of all opinions and persuasions to get behind efforts. A lot of the discussion will come down to priority of resources.
It usually does. So tell people how they can follow along with the testimony that your committee is getting, because much of the statistics I read to you are in documents that were presented at that committee.
It's really, it's very easy. If you go on to the Texas House of Representatives website, there is a link at the top of the page that is just committees, and so all different committees are listed. And the Opioid and Substance Abuse Select Committee, which is studying not just opioids but substance abuse in Texas during this interim period, so between now and next January, all the committee hearings are archived, so you can watch them live when they're scheduled, or you can go back and listen to the testimony that's been presented, because it's all archived on that website. And then all the handouts and all the materials that witnesses bring to those hearings, that's what you're referencing, I believe, they are listed there as well. So there's a tab. And so, for instance, we had, you know, the Department of State Health Services and SAMHSA and pharma and witnesses from all different, you know, backgrounds come and testify last month. And all that information that they brought to the committee is available to the public. So you can scroll down and look at what you want, or print it out, or whatever you want to do. But all our committee hearings are posted. We have one in April. We'll have another one in May. We'll probably have June, August, and September. And then if we need some additional hearings, we will. But that's the easiest way to do it, is going online, instead of traveling 500 miles to the Capitol to watch it in person.
Okay, yeah, that's the option I'm going to use. We now have time for some questions from the audience. We've got a mic handler who's going to bring you a microphone so you can be heard for our Facebook Live group as well.
I'm Teresa Kennedy. For 20 years, I did drug prevention for Amarillo ISD from 1991 to 2010. And at that time, we had probably 2 to 3 teen treatment centers here that focused on our adolescents. Unfortunately, that funding went away. They closed down. Nothing happened. So glad to have you back. Okay. My question is, when I left in 2010, and the reason I left is the funding ended. It was safe and drug-free schools and communities went to fund for prevention specialists, and then nothing. So I agree about the treatment. I think it's critical to have. However, I'm really concerned about what are we doing on the prevention side. Because we spent a lot of time, probably the last 3 or 4 years of my time there, on prescription and over-the-counter drugs. What this did to you, what was happening to you, because kids were just starting to do that, you know, throwing the Skittles in the bags and all that stuff, and you know, everybody brought their different Skittles, which were their different drugs, to put in this bag, and then you just pull it out, overdose, right? Or not, if not overdose, just get very high from it. And so I'm wondering, where are we with that today? I've been gone out of that system, really 3 years, but out of that programming for 8. And I'm hoping that we're still continuing the prevention side. Because I agree that we need funding toward treatment, and you're it, ARAD's it, which is unfortunate. So if we're dealing with prevention, that'll help you have less people that come for treatment. If we're not, we need to get there. And really, we need to get there with some funding again, because removing that funding did not remove the problem. Look where we are today. In fact, I believe it made it worse.
Can any of you answer where we are with youth programs? And
Well, I've been around a while, and, I remember it was in the mid-90s that adolescent programs just started shutting down all over the United States. And there's kind of a gaping black hole where adolescent treatment used to be. And I think it was, I was in Michigan at that time, and I just know that it was like, so then we were just inundated with kids in outpatient programs and kids going through the courts and that kind of thing. And so they were already, and, of course, there's family history of addiction and that kind of thing. That's never, how sometimes they say, well, the pendulum swings this way and then it swings back the other way. Well, I keep waiting for it to swing back that other way. But money for mental health and substance use has been shrinking and shrinking and shrinking in general terms since the 1980s. So there's so much less available in general, I would love to see an adolescent treatment program here in this town. And if we have anything to say about it, there's going to be one. That's something that's already kind of on our radar, and it was a conversation I had with Perry Gilmore on the board the day that I interviewed for my job. It's just like, is there anything for kids? Let's build that too. But of course it takes time, it takes money, it takes effort, and because there's not public funding for it, then there's the dilemma of asking people to dig deep, and so I don't know what I have no idea what the state has in mind about supporting anything like that for kids. I'm certainly willing to advocate for it and do whatever I can to participate in that. And I agree with you that prevention needs to be happening. And I really think, I already told you my bent, which is that it needs to be happening at a family and community level, not just in the schools.
thank you. Ford, do you know?
Yeah,
is that a focus in your committee?
Well, it's more of an issue in the Appropriations Committee in terms of actual funding for programs, Teresa. The thing that I've seen is a lot of the money that's appropriated through Article 2 in our budget, which is the Health and Human Services portion, goes to the Department of State Health Services, for instance, for prevention programs. And there is funding for several prevention programs. A lot of it for adolescents is focused on tobacco cessation, quite a bit actually, and so, when you start getting, I guess, more in the weeds, or you start to parse it out into other types of, programs, I think in the past, at least what I've been familiar with or exposed to has been, there'll be grant programs for things like Just Say No to Drugs, and these programs that come, and they might last 5 years. But as soon as that money dries up, then another product or program has to be, approved, and then it takes a year or two to get that passed and implemented. And so you go through these cycles where, depending on available resources, and of course the state's on a biennium, so it doesn't know 5 years from now what it's going to be able to spend. It only operates in 2-year cycles. And so when times are good economically in the state, we have more money to appropriate. When times are economically flat or recessed or depressed, then we actually start looking for areas, to cut back. And, I just have to go back and look. I think prevention dollars sometimes have been, good in good years and low in poor years. And that consistency is something that's been, kind of lacking. But there are programs, some of them are funded. Some school districts do things on their own with the money that they receive that aren't mandated statewide. and I'm aware of some of those programs. Some communities are much more proactive than others across the state in how they deal with it and who they partner with or collaborate with to provide programs for our youth. But from a statewide perspective, you know, with 28 million people, 5 million kids in our public school system, it gets very costly, obviously, to mandate a program that the schools have to implement unless the state puts all the money behind it. And so that just kind of goes in some cycles.
I think also, too, Ms. Kennedy, on the prevention side, it gets a lot more difficult to prove whether it works. You know, in law enforcement, I'm sure you heard of DARE, and for years we did that in the jurisdiction that I was in. Not just our program, but nationwide, they concluded that that didn't work. We applied for other grants for other things to try to get some programs in place, but you got to be able to show that they're going to work. And it's probably easier for Martha to show she's got someone who's addicted now, and now they're not, versus, you know, how many people did you stop from becoming addicted in the first place? And that becomes a problem, I think, from a grant perspective.
That's a good point. Another question was over here, I think.
Thank you. My name's Floyd Anthony, and my question is, what does the demographics for opioid abuse look like?
You know, Mr. Anthony, in our hearing, and I don't want to misquote it, but I was a little surprised. I don't know why, but it seemed like the largest demographic for opioid abuse tended to be, if I remember correctly, it was, and Martha, you may know this, but it seemed like it was middle-aged white males was kind of the largest abuser of opioids. And I can't remember the exact age, but I'm going to say it was like, you know, 30 to 45 years old or something in that neighborhood. And so that's what I recall from the testimony in our committee.
Right. Well, and one of the things I was thinking about why it is maybe not as visible is because it takes a while for there to be a progression of any addiction to any substance. But the other thing is, it's kind of if adults, middle-class adults, are abusing prescription drugs, and they're largely functional at their jobs and their family lives, they're kind of invisible. They're sort of floating under the radar. So they're not out there busting in people's cars. They're not doing that stuff because they don't need to, because they can get it other ways. But so they're functioning addicts. They're people who look just like all of us. And it takes a while. It takes a period of years sometimes for their health to start to deteriorate or for the impairment to reach the level that it's visible and obvious to somebody else. And so that doesn't mean that it's not here. It just means we're not seeing it in the same, and it may not even be that population that you're describing.
Yes.
Shmaso, and I'd like to know, when I was coming to this today, I was looking up different drugs that were opioids. And I was a little upset to find out that the pain medication that I take is listed under that. One of the things that I think we need to get doctors to do is to talk to their patients. If you're taking pain medication, and I take it because I have back and knee problems, but if you're taking pain medication, people like me need to know that just don't tell me, oh, well, we're worried about it being addictive. Why are you worried about it being addictive? It's an opioid, and I think if more people like myself knew that, we might be a little bit more cautious with it.
There was a question over here. Toward the back there. And I see two more hands, and that's what we're going to have time for.
I've prepared a 2-minute statement, if that's okay.
Do what?
I've prepared a 2-minute statement, just 2 minutes. My name is Denise. I'm a registered nurse, and I'm here tonight as a patient advocate. Healthcare professionals are intimately involved in the war on drugs, and there's a tendency to view the opioid crisis as a crime wave, where I'm inclined to agree with Martha and view it more as a public health crisis. I've treated countless casualties of this war. In 2016, as you've heard several times tonight, 64,000 Americans died of drug overdoses. In that same year, 88,000 died of alcohol-related causes, but no one's declaring a national health emergency about our alcohol problem. And we know from our own history that alcohol prohibition was a catastrophic failure. Yet we persist in our drug war to the extent that legalization has not even been discussed tonight. Nursing is rooted in evidence-based practice. Everything I do for my patients is because a peer-reviewed study says it may be helpful. So I've turned to areas that have had success in fighting their opiate crises. Switzerland, providing needle exchange programs, methadone clinics, and medically supervised injection centers for drugs like heroin, in 10 years saw a 50% decrease in both HIV infection and overdose deaths. A little closer to home, Colorado has seen a 6% drop in opiate deaths just in the 2 years since legalizing recreational marijuana. Evidence-based practice would be to decriminalize, regulate, and rehabilitate. So my question is not what should we do, but when are we going to start? Thank you.
You know, and ma'am, you raised a good point about alcohol, and we have a huge DWI problem here. We had 27 people died in traffic crashes last year. We had 28 died in traffic crashes the year before that. More than half were related to DWI. But I think to compare alcohol, though, to our opioid and other illicit drugs is really not fair, because you have to look at the number of people who drink alcohol and then who end up perishing because of that. And in many cases with the alcohol numbers, they include car crashes, vehicle crashes, that they don't include with other drugs because, they don't, I mean, you just don't do that same kind of surveillance out there. So alcohol is a problem, but not near to the degree. I mean, I don't want us to lose focus on the illicit drug problem. And again, alcoholism is a problem. We know that. It causes a lot of health issues, causes a lot of traffic crashes. But a lot of people drink alcohol. A lot of people drink alcohol who do not have a problem, and it's very tough. If you start using heroin or some of these illicit drugs out there, you are going to become addicted. If you use meth and you use it regularly, you're going to become addicted, period. And I don't know if that's the same case with everybody who drinks alcohol.
Anyone else want to add to that? Okay.
Well, I would just say that it's true that not everybody who uses alcohol is going to become addicted, but I would say I'm going to lean the other direction a little bit, in that even though it may not cause the same, it may not cost the same in terms of crime and fatalities as other drugs do, just in terms of the collateral damage and the social damage and the child abuse and neglect and the spousal abuse and white-collar crime and on and on and on. I mean, it's a huge cost and it's a huge problem. So even though not everybody becomes addicted, sometimes people who aren't even addicted can have serious problems as a result of it. You can still get a DUI, you can still kill somebody in a car crash. But for the people who are addicted, again, it's a socially acceptable thing. It's something that it takes a long time to see the destruction in somebody's lives in some cases, but it's no less insidious, I think, than the other substances. And
I don't want you to think I think alcohol is not a problem. In fact, just last week, I was amazed here. I got here and there's no MAD, and so there's a rep down in a victim's advocate down in Lubbock, and so we're going to try to get at least a volunteer group going here in Amarillo to try to address that problem. So I realize alcohol is a bad problem here.
Thank you. The question here and then the one in the back. So.
I wanted to thank you guys for coming today. And this is where it starts. This is where we start coming together, everybody collaboratively. We're all a piece of the puzzle. I am with prevention, and we do work with youth here in Amarillo in the upper 26. And we also have the lower 26 also works in prevention as well. There's not one easy solution, but I think starting it in a conversation like we are tonight is going to make a big difference. And I think that it's also the parents. And it's also social media. Who's addressing social media? That has such a grip on kids. It can actually alter your brain patterns as young as 8. I've seen kids as young as 3 starting on cell phones. I mean, it's so many different levels, but I think when we start having conversations and then we start working with families together in the community, we can really make this happen. It's not going to solve everything, but we can help people turn away from it. Thank you.
Thank you. The one man in the back.
My name is John Hancock. I personally do not have any experience with opioid addiction as far as myself, but I've seen my mother become addicted to prescription drugs. I've seen several friends just since I've lived in Amarillo, about 7 years now, who have become hooked on meth, and it seems like there's no option for them. It seems like funding is a big obstacle. Looking back at the 2017 population report, it looks like there's about 275,000 people in Amarillo. You know, we have this ballpark coming up, which is going to be additional in taxes, stuff like that. Why can't we offer some sort of community initiative, charging the people, the 275,000 people here, an extra $5 in taxes? That's $1 million, and that's only $5 per citizen. You know, go ahead and bump that up to 10, 20, and start an initiative to help fund these programs, to help this prevention, and to help the recovery. Is that something that would be feasible?
Thank you.
I think that's Representative Price wants to.
Yeah, you're in on this one.
Well, thank you, Chief. I appreciate that. And I think, you know, your idea about the community pulling together to address a problem that is you know, it's a problem everywhere, but each community, it may suffer from different, you know, nuanced issues. I mean, as the Chief said, I mean, opioids is a problem, but maybe, you know, locally they see from a criminal justice side, you know, more methamphetamine, you know, abuse, and then ancillary crimes related to that. But, you know, so involving the community to come up with a solution locally often is very, not only, you know, a good idea, but it's very successful in terms of the outcomes that result from a community initiative, because it's actually getting at the heart of whatever the problem is that's affecting that particular community. Texas is so big, and you mentioned, you know, the MSA of Amarillo being over 200,000. Well, you know, we have 28.3 million Texans. So often when we say, here's a solution that everybody has to do, and, you know, here's the idea, it doesn't always look the same in McAllen as it does in Tyler, as it does in Amarillo. So that's really difficult. So when you're talking about a local solution or a local initiative, I think, you know, the idea of that is a very, very good one. When it comes to, you know, taxation or raising money for that, then it becomes, you know, a little more complicated, in my opinion, because, you know, for instance, a local initiative then would have to be funded through some sort of local taxing entity. So whether that be, you know, the county or, you know, hospital districts or, you know, some local taxing entity, then those, each entity has its own constituency. And so when it comes to raising, you know, any dollar of tax, it becomes politically very hard to do. Even in the, you know, most commonsensical, you know, approaches to some of the most common problems, you'll see that that's really hard to do. And so, you know, just look at our recent bond issues and things like that. Sometimes they pass, sometimes they fail. It depends what everybody's priority is. What I think is good about meetings like this is you are starting a conversation and raising awareness on issues that are affecting everybody. Like I said, it's not just, you know, one segment of the population or one area of town or anything like that. It's affecting everybody. So this gives people an opportunity to get more educated and create, I think, opportunities for discussions that will lead to ideas. You know, at a state level, it's very difficult. You know, in the 4, you know, terms that I've been there, we have not raised taxes, period, for anything. And in fact, we've cut them for property, you know, taxes and the like. So I'm, you know, sensitive to that. I think the political realities, that's very difficult. But I think the idea about addressing problems at a local level makes the most sense.
Okay. I want to thank all of our panelists and all of you who joined us, whether you're here in this audience or at our Facebook Live audience. The live stream of this event will remain on our Panhandle PBS Facebook page, so if you see it there, please share it. The more this conversation can be shared and other people can be informed, the better. And we'll also upload that video, as I said, to our website, panhandlepbs.org. This is the first of 3 forums that Panhandle PBS and the Amarillo NAACP have planned. The next one will cover sex education and that curriculum in our schools. It will be on Saturday, July 14th, and at the Southwest Branch Library. Now, I'll turn things over to Mr. Floyd Anthony. He is the president of Amarillo NAACP.